Hello, friends. A very good morning to all of you. So, hope you were able to perform to the best of your abilities in your FMG exam, and I'm sure you've done really well. Though, the overall impression which I got from you students is this time the FMG exam was moving more towards the next pattern, and overall, probably, the paper would be rated maybe as moderate to difficult by most of you, but I believe the pediatrics questions, as always, were really very, very simple and very easily doable. So, till now, I have been able to get almost 18 questions from pediatrics, and almost all of them have been very well covered in our videos, and many of them have been covered in our FMG marathon session also. So, I hope you've done your pediatrics really well. Yes? And I look forward to a very useful interactive session with all of you. So please confirm if I'm audible and if my screen is visible. Yes, waiting for your reply. Good morning, Gausalya, Shifali, Manoj. Am I audible and is my screen visible? Please confirm. Yeah, thank you. Okay, thank you. Right. So, in this session, we will be briefly, discussing the recalled questions from pediatrics. And these questions may not be, exactly the same. The wordings might not be exactly the same as was there in the exam. But this is purely based on the recall provided by you students. So, let us see. We will, together we will try to arrive at the, most actual questions. And if you can help me with if any changes are required in the questions, the options, okay, and it will definitely be very useful, and you will also be able to confirm whether you've answered the questions correctly or not. So it is a win-win situation for all of us, and now I agree is a time to relax. But in the 24 to 48 hours after exam, that is the best time when you can recall the questions, when you can try to analyze where did you went wrong, or like you've been correct or not. So give some time to that, and definitely it is going to help you in your future also. So we will just be quickly going through the questions that came from pediatrics. So let us start. Yes. So a very basic question: a child presented with short stature. Okay, so what we have is short stature. His bone age is less than the chronological age. Okay, so bone age is less than the chronological age. That means if the skeletal x-ray was done, suppose the child is say 7 years old, but the bone age, the x-rays will show that the child's age is maybe 4 years or 5 years. So bone age is less than the chronological age. The height of his parents is normal, so the parents have normal stature. Parents are not having short stature. What is the diagnosis, right? So is it constitutional short stature, or familial short stature, or cretinism, or malnutrition? So let us try to analyze the options one by one. So constitutional short stature, yes, very good. Gosalya, Pradhana, Shifali, very good. Yes. So Khan Brotherhood, right. So it appears to be a case of constitutional short stature, because we know in constitutional short stature what happens? The height of the parents is normal, and during childhood the child's height is less than expected, but then the child catches up and the ultimate final height attained is normal. So the pointers which are pointing towards the diagnosis of constitutional short stature here is the parents do not have short stature. The height of parents is normal. That means it cannot be familial short stature. In familial short stature, the parents would also have been short, and the bone age would have been equal to the chronological age. Cretinism, no, there are no other stigmata pointing to a diagnosis of hypothyroidism here. With hypothyroidism, the child might have had intellectual disability, obesity, okay, and many other problems. Malnutrition, no, we are not provided with any other nutritional markers here. We've not been told that the child's weight is less than expected, or the child is not gaining weight adequately, okay, or any signs of micronutrient deficiency. They've not been mentioned. So the diagnosis here is undoubtedly constitutional short stature. Okay, yes. So familial short stature, we already mentioned familial short stature. What will happen? The parents will also be short. Okay, parents would have short stature. Parents would be short. But in CDGP, constitutional delay in growth and puberty, the parents' height is normal. Okay, parents' height is normal, right? In familial short stature, the bone age would be equal to the chronological age. But in constitutional delay in growth and puberty, the bone age is less than the chronological age. Okay. And the puberty is attained at normal time in familial short stature. But in constitutional delay in growth and puberty, you can get delayed puberty. So these would be some of the important salient differences between these two entities, right? No confusion? Okay. Now, so some of you are telling that the question was a little different. What was the question exactly? If someone can help me. Honey says it was the same. Praful says in question parents' height was small. Okay, so if the parents, suppose in the same question, if the parents' height was short, okay, if the parents had, so let us put it this way, if the parents had short stature, okay, if the parents also had short stature, and if the bone age would have been equal to the chronological age, then I would have gone with the diagnosis of familial short stature. Okay, right? So if the parents also have short stature and the child's bone age is equal to chronological age, then the diagnosis would be familial short stature. So what do you think? So was the case scenario of familial short stature or constitutional short stature? What do you feel? So Nagendra and Yugdeep feel the question was same. Okay. So, whoever remembers the exact question, please help me with that. Okay, in the options in the comment box, you can write. Okay, and but irrespective of the question, I hope you're getting the point. So, if in the question the parents are of normal height and bone age is less than chronological age, then your answer would be constitutional short stature. But if parents have short stature and bone age is equal to chronological age, then your answer would be familial short stature. Right? Okay. So, some feel that it was familial short stature. Some of you are feeling it was constitutional. So, guys, make up your mind. We'll count the majority then. So, moving on to the next question. Again, a very, very basic and question we've discussed n number of times. And so, this was an 8-month-old child who was found to have, in fact, we've covered in marathon also, I think, an 8-month-old child was found to have features of vitamin A deficiency. So, there was probably some dryness of eyes or, xerophthalmia, which was mentioned in the question, right? What is the dose of oral vitamin A required? Okay, so this is a 8-month-old child, right? So very good. So your answers are right. Yugdeep, Shifali, Vaibhav, Tufail, Bunny, Praful, Khan, awesome. Binuradha, Gausalya. Okay. So we all know it is a very, very important, often repeated topic. Okay. So I'm sure all of you have made it correct. So at 6 months, we know the dose of vitamin A per dose is 50,000 units. Okay. Age less than 6 months, 6 to 12 months, it is 1 lakh international units per dose, and more than 1 year, it is 2 lakh international units per dose. So I'm sure all of you have answered it correctly. It is 1 lakh international units is the answer here, right? Moving on to the next question. Which nutrient deficiency can cause collagen defect? So was this the question? So was it so straightforward? Yes. So which nutrient deficiency can cause collagen defect? Is it vitamin A or vitamin B complex, vitamin C or vitamin D? Yes. Tell me. So, what was the question? This was the question. Which nutrient deficiency can cause collagen defect, and what do you think is the answer? So, Yugdeep says yes, it was a straightforward question. And again, no points for guessing this. So, we all know this is, vitamin C. Vitamin C or ascorbic acid helps in the synthesis of collagen. And in fact, the definition of the deficiency of vitamin C causes, yes, who can tell me the deficiency of vitamin C causes what? So, again, we've discussed it in details. Yes, waiting for your answers. Deficiency of vitamin C causes. Okay, so copper was also the option. Okay, vitamin C and copper was option. Very good. Pradhana, Gausalya, Yugdeep, Praful, Rao. Okay, so it is scurvy. It's not scary. Your drug of choice writes it's scary. So it's not scary, it's scurvy. Maybe it's auto corrected by your phone. Okay, so it was a straightforward question. I'm sure all of you have done it correctly. So it is vitamin C. And if copper is there, vitamin C and copper, that's also fine, I guess. Okay. So next question, again we have discussed in our videos also, and we've discussed in marathon also, true statement regarding the image given below. So what you can see is a malnourished child, okay, and the child is totally emaciated. There doesn't appear to be any edema, okay, the child is emaciated, you can see, right? So what is it? Is it kwashiorkor due to less protein intake, or is it B, marasmus due to less protein intake, or is it C, marasmus due to less calorie intake, or is it D, kwashiorkor due to less calorie intake? So, in this picture which we see, there is not much of edema. Actually, the child is appearing quite emaciated, apart from, just abdominal distension that is there. So, if the child is totally emaciated and there is no edema, then we will mark it as marasmus due to less calorie intake. Okay. But if edema was also there, then we will mark it as kwashiorkor due to less protein intake. So, guys, help me. Was this the exact image? So, was edema there or not there? Yes, so was edema there in the question? Was this the image or the image was different? Okay, Dr. Angel feels that there was edema. Okay. Nagendra also says A. So if there was edema, significant edema along with malnutrition, then it will be kwashiorkor due to less protein intake. Okay, if edema was there, significant edema was there, then it would be kwashiorkor due to less protein intake. If there is no edema as such, the child is just emaciated, then it would be marasmus due to less calorie intake. Okay, so different image. So if anyone can help me with the image, I'll show my email address in the end. Either you can email it to me or share on the Telegram group or share here in the comments below after this session ends, because these comments will go away once the session ends. Okay. So please share after the session ends. So there's this Wellcome Trust classification of malnutrition which we have discussed many a times. So if weight for age is 60 to 80% of expected, edema is absent, then it is called undernutrition. We know. Okay. If the weight for age is like less, okay, 60 to 80% of expected, and edema is present, whenever edema is present, it becomes kwashiorkor. Okay, it becomes kwashiorkor. Okay, right? Now, if the weight for age is less than 60% of expected, but edema is absent, okay, edema is absent, then it becomes marasmus. Okay, so emaciated child, edema absent, it becomes marasmus. If the weight for age is less than 60% of expected, but edema is also present, so lot of emaciation along with edema, it becomes a category that is called marasmic kwashiorkor. Okay, so your image will give you the answer. If edema is there, then go with kwashiorkor, and kwashiorkor is mainly due to protein deficiency along with calories. And if edema is not there, then go with marasmus. Okay, now moving on to the next question, again a pretty straightforward question. So this is a 5-year-old child, who develops a fever with rash, also had cough, conjunctivitis, coryza. So you can see this child has a wet kind of a look. Okay, so the watery eyes are there, runny nose is there, fever with rash is there. It appears to be a maculopapular confluent kind of a rash. There is conjunctivitis also. So what is your answer here? So again, a pretty straightforward question. I'm sure all of you have done it correctly. Is it measles or chicken pox, erythema infectiosum, hand, foot, mouth disease? Yes. So yes, Dhruvil, you're right. So Bunny, Dhruvil, okay, Wasim, thanks for confirming the image. Shifali, Wasim, yes. Binuradha, so it is measles. Yes. Okay. So the wet kind of a look, the conjunctivitis, coryza associated fever with maculopapular rash, this indeed is measles. So what kind of a rash we have in measles? So in measles we have this erythematous maculopapular rash. Okay. Erythematous maculopapular rash, and with fever of course, and it becomes confluent also at places, merges with each other, and the child has a wet kind of look, and there is associated conjunctivitis is there. Okay, coryza or running nose is there, right? Chickenpox, what kind of a rash is there? So chickenpox is basically known for its pleomorphic skin rash. That means you will have macules, vesicles, papules, pustules all at the same time at different places. Okay, so it is called pleomorphic skin rash. So different types of skin rash at the same time is characteristic of chickenpox. Some of the lesions might crust also. Erythema infectiosum, you typically get what? So you get a slab cheek appearance of rash. Okay, so it is caused by parvovirus, and you get a slab cheek appearance of rash. Okay, redness on the cheeks. So slab cheek appearance of a rash, and hand, foot, of mouth disease, you get mainly vesicles. Okay, so hand, foot, of mouth disease, you get vesicles or blisters in the oral cavity, on the hands, and on the soles. Okay, so that is the typical presentation. Now moving on to the next question. Again, it is so simple question, guys, and we've discussed it n number of times. I'm sure again you've made it correct. So within how many hours, okay, within how many hours can breastfeeding be initiated in a perfectly healthy child with no anatomical problems? Is it 1 hour or 4 hours or 24 hours or 48 hours? Yes. So, all of you, Dr. Angel says 24 hours. No, 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 dear. Okay, Faiz, good. Gausalya, Basit, Shweta, Wasim, very good. So, it is 1 hour. So, ideally, it should be started as soon as possible, and within 1 hour of birth, breastfeeding must be initiated. And we all know exclusive breastfeeding is to be done for first 6 months of life, right? Now, this was a question fluid of choice for shock in a child with severe acute malnutrition. So, fluid of choice for shock in a child with severe acute malnutrition. So, normally the fluid of choice for shock, okay, in a child, the fluid of choice for shock in a normal child, it would be normal saline, okay. But in a child with severe acute malnutrition, one is we will avoid intravenous fluids as much as possible. But the child, if the child is having severe shock, then we might have to give fluids. And in that condition, so in a child with severe acute malnutrition, though it is a controversial topic, but in a child with SAM, we would prefer. Yes, can anyone? Okay, hypoglycemia was also mentioned in the question. Okay, so hypoglycemia was also mentioned in the question. Okay, right? So, in this situation, very good. So, dextrose alone cannot be given. Shweta, no. Dextrose alone never to be used in shock. So, you can use a fluid which also has dextrose, but dextrose alone will not be useful. So, the best answer here would be ringalactate plus 5% dextrose. Okay. So, a combination of, crystalloid along with 5% dextrose. But dextrose alone, 10% dextrose alone would not be used. Normal saline would have been preferred if the child did not have SAM or hypoglycemia. Again, ringalactate we could have given if there was no SAM or hypoglycemia. Okay. So the best answer here is ringalactate plus 5% dextrose. Dhruval says NS in normal child. Yes, good. Okay, 10% dextrose with shock, RL plus dextrose. Yes, so Dhruval has summarized it very nicely. So in normal child, if there is shock, normal means a child without malnutrition. Of course, with shock, a child is not normal. So in a child without malnutrition, if shock is there, normal saline is the answer. Okay, in a child with severe acute malnutrition, if just hypoglycemia is there, then 10% dextrose would have been the answer. But in a child with severe acute malnutrition, if shock is there, then ringalactate with 5% dextrose is the answer. And you will give the fluid boluses slowly, 15 ml per kg or so over 1 hour, right? Because they can go in fluid overload also easily. Again, a very, very simple question. And again, we have discussed in our videos which of the following are not correct about ABCD in pediatric advanced life support or PALS. So we know in PALS the ABCDE, A stands for airway. So B stands for breathing. So you assess the airway, you assess the breathing. C stands for circulation. What does D stand for? Very good. So you've already answered it. Sneha, Havok, Osama, Shifali, Shweta, your drug of choice, Gausalya. Very good. So D stands for, what does D stand for? Can anyone tell me? What does D actually stand for in PALS? Very good, Govardhan. So it is disability. So disability means you have to look at the neurological status of the child. You have to assess the sensorium, the level of consciousness of the child. So that is the disability. And there is also E that stands for. What does E stand for? Yes, anyone? So E stands for exposure. Okay, you have to expose the child adequately. Okay, as much as is required to, examine the child properly. So which of these are not correct about PALS, right? So not correct is there in the question. So what will be our best answer? D, dehydration. Okay, very good. Awesome, guys. Right, moving ahead. So again, such a straightforward question. I mean, I cannot help but wonder that pediatrics would have been so scoring in this exam. So you can clearly see that the questions are. I am sure you most of you have done everything correct from pediatrics. So which enzyme is deficient in von Giarke disease? So was this the question as simple as this? So we all know von Giarke disease is a glycogen storage disease type 1, and it is due to the deficiency of glucose 6 phosphatase. So was this the question, guys? And please confirm what were the other options. So okay, great. So this was the question. So you can see again, so simple. So it becomes very scoring subject for you now, right? Okay, so what were the other options? Can someone help me with the two other options? What were the options? Okay, so doll like baby was there. In the question, doll like baby was also there. So that again helps you clench your diagnosis. So doll like faces was also there in the question you are telling. Okay. And other options were okay. So one was debranching enzyme and the other was fructose 6 phosphatase or so. Debranching enzyme and fructose 6 phosphatase. So were these the options? Fructose 6 phosphatase. So some of you are telling okay, so not simple single liner. So what else was there in the question? Can somebody tell me what else was there in the question? So Manoj, good to hear. And actually इस बार सच में बाहर से कुछ नहीं आया. So it was like so heartening that it like everything have we have covered very well in our videos. So I'm sure you if you would have gone through the videos, you wouldn't have made a single mistake in pediatrics. So बताओ, what else was there in the question? Some case scenario was there. So doll like faces you're telling whether hypoglycemia or abdominal distension or hepatomegaly, any of these was mentioned. Okay, Akhil Raj feels it was a simple one liner. कुछ नहीं लिखा था. Okay. So first option was not there. Glucose 6 phosphate dehydrogenase नहीं था, उसकी जगह क्या था? Then what were the options? So debranching enzyme था, fructose 6 phosphatase and aldolase था. What was another option? Aldolase. So no case scenario. Okay, only single line question tha. So first option was aldolase or what was the option? Phosphorylase was the option you're telling. Okay, phosphorylase. Muscle phosphorylase was probably the option then. Okay, aldolase भी था. So fructose 6 phosphatase नहीं था क्या? Okay. So help me with the options. Okay, we move ahead. So again, now tell me, who would make mistake in this question? A post-term neonate is a neonate that is born. So we all know, I think in your sleep also you can tell me, a term neonate is a neonate who is born between 30, who is born between, yes, 37 completed weeks to less than 42 weeks gestation. So just this definition if you would have remembered, and I am sure you would have. So post term neonate किसको बोलते हैं? What do you mean by a post term neonate? So who will tell me the answer? Is it A beyond 37 weeks? Is it B beyond 38 weeks? C beyond 40 weeks? D beyond 42 weeks? So what is the answer here? So very good, Shamshad, Binuradha. So D is correct. Again, no points for guessing this. So this is so simple. So a post-term neonate is a neonate that is born, we all know, beyond 42 weeks. And preterm would be baby born at less than 37 completed weeks of gestation. Okay. Moving ahead. According to the neonatal resuscitation protocol, chest compression is initiated at heart rate below. So who will tell me the answer? Chest compression is initiated at heart rate below. So is it 80 per minute, 75 per minute, 70 per minute, 60 per minute? So Devendra, Akhil Raj, Manoj, Kusai, Snehal, Nikhil, Angel, Shivam, very good. So all of you are right. So it is 60 per minute. So again, in our main videos also, in marathon also, we've discussed the neonatal resuscitation protocol, and you can see the neonatal resuscitation guidelines. I'm not going into a detail at this moment because this is the time for you to relax. I'll just point out the answer to you. So, we can see that heart rate less than 100. So we did positive pressure ventilation. Okay, at heart rate less than 100, we did positive pressure ventilation. Okay, and we checked the saturation and we monitor the saturation and we consider ECG monitor. When the heart rate becomes less than 60 per minute, then we start chest compressions, right? So it is clearly mentioned in the resuscitation guidelines. Okay. Now, again, another question was there in the neonatal resuscitation guidelines, on the neonatal guidelines. So according to the neonatal resuscitation protocol, how much oxygen to be given in a term neonate with apnea and bradycardia initially? So again, going back to the neonatal resuscitation guidelines, so who will give me the answer first? Is it A 21%, B 30%, C 50%, D 100%? Yes? What is the answer? No, waiting for your replies. Okay, so initially is the keyword. Okay, initially. So there is initially in the question, how much oxygen to give in a term neonate with apnea and bradycardia? Lakshyarth is right. Okay, so let us see. So, if a baby is there, term gestation, good tone, breathing or crying, and the baby is having apnea, okay, that means not breathing or gasping, and heart rate below 100 per minute, that means bradycardia. So apnea or gasping or bradycardia is there. What will you do? You will do positive pressure ventilation. You will monitor the saturation and consider ECG monitor. But nowhere it is mentioned here that you supplement oxygen. There is no mention about supplementation of oxygen here. Only if there is labored breathing or persistent cyanosis, then you think of supplementary oxygen as needed. So if only apnea is there, heart rate below 100 per minute, that means bradycardia is there. So initially you always start with 21% oxygen, that is room air. So even if you're doing bag and mask ventilation, you start with room air. So initially it has to be 21% oxygen. So this is a slightly tricky question, but if you have gone through your neonatal resuscitation protocol properly, so I'm sure you would have answered it. So a 21%, so we always start with room air in a term baby who is requiring positive pressure ventilation because of apnea or bradycardia. Initially we will always start with room air, but if despite your positive pressure ventilation with room air the baby continues to have bradycardia and the heart rate then becomes 60 per minute, less than 60 per minute, then you will start chest compressions, continue positive pressure ventilation, and then you will give 100% oxygen. So if heart rate becomes less than 60 per minute, then you will give 100% oxygen. But initially, when the heart rate is less than 100 per minute and initially when the baby is having bradycardia or apnea, you will give positive pressure ventilation with room air, that means 21% oxygen. Okay, right? Okay. So even if there was positive pressure ventilation, we start with room air in a term baby. Okay. So moving ahead, a neonate is unable to open the eyelid. Okay, identify the condition given in the image below. So what do you see here? So this is a reddish colored lesion in the neonate because of which the baby is not able to open the eye. So is it a capillary hemangioma A, or is it B, Mongolian spot? Is it C, media? Is it D, erythema toxicum neonatorum? Again, a pretty straightforward question which we've discussed n number of times in our videos. So yes, so Nikhil, Snehal, Gausalya, Shweta, Akhil, Shivam, Ravi, all of you are right. So it is indeed a capillary hemangioma. Okay. So because of this capillary hemangioma, the baby is not able to open eye, so you need to treat it. Usually propranolol is the drug of choice that is started. Sometimes you might have to resort to steroids. And early treatment is important in this case because if the baby is not able to open the eye properly, then amblyopia and all can develop because of the disuse. So it is important to treat this baby. So this is a reddish colored lesion. It is a capillary hemangioma which is present since birth on the skin. Okay. Mongolian spot doesn't look like this. They are bluish black lesions, patches over the lower back and buttock region. Melia are colorless papules which are due to plugging of the sweat ducts. Erythema toxicum neonatorum is mainly on the trunk and it is a transient kind of lesion, erythematous maculopapular rash which is innocuous, requires no treatment. Right? Capillary hemangiomas also, if they are very small, they do not need any treatment. But if they are this big and they are causing some problem with opening of eye and all, then yes, it would need treatment. Okay? Now, moving on to the next question. Okay, so Aarti says cavernous hemangioma was one of the options. So even if cavernous hemangioma was option, that will not be the answer here because cavernous hemangioma usually involves the viscera, while in the skin capillary hemangioma is more common. Okay. So the next question: a child was brought with a history of frothiness from mouth and respiratory distress. X-ray of the child is given below. So there is a child, or probably it was a neonate. Was it a neonate? I think it would have been a neonate. A neonate was brought with a history of frothiness from mouth and respiratory distress. X-ray of the baby is given. What is the diagnosis? So is it transient tachypnea of newborn? Is it hyaline membrane disease? Is it esophageal atresia with tracheoesophageal fistula or Bogdalic hernia or diaphragmatic hernia? So only option was there, tracheoesophageal fistula. That is okay. Even if it was only tracheoesophageal fistula, then also, we would have marked it correct. So yes, all of you are right. Yes, I know rapid revision was actually sufficient to solve this paper. So, pediatrics was definitely this time class apart, I would say, different from rest of the paper. Because rest of the paper, I got the vibes that it was probably more difficult towards a neat pattern, but pediatrics thankfully was still the same. So still sticking to the basics and keeping things simple. Right. So you can see here, can you appreciate this coiled structure here? Okay. So this appears to be a, feeding tube which is getting coiled and which is not going inside. So this appears to be a case of esophageal atresia or tracheoesophageal fistula. So it is not going inside. Okay. So yes, this is the answer here. TTNB, usually you will not get such a picture OG tube will easily pass and you can get some fluid retention in the lung fields. Hyaline membrane disease, you will get a ground glass kind of appearance and preterm baby would be there. Diaphragmatic hernia, we all know what the x-ray is like. There will be bowel gas shadows in the thorax and mediastinal shift and so on. Okay, right. Next question, a 5-year-old child who has taken 10 iron tablets presents with nausea and abdominal pain. What is the antidote of iron poisoning? So you have a 5-year-old child who has taken iron tablets. Okay, so for chelation of iron, so nausea and abdominal pain is there. So what is the antidote of iron poisoning? So we all know what are the chelating agents used in thalassemia for excess iron overload to treat that. So is it penicillamine or British antileucide or EDTA or desferrioxamine? So yes, very good. Shefali, Muskan, Rao, Snehal, Manoj, Hira Ram is not right, I'm afraid. Akhil, okay. अच्छा, Trilok says एक pedigree का question भी था. Please share the pedigree question if anyone remembers, then we can discuss that. So what exactly was the question? Was a picture of pedigree given and what was asked? Directly the mode of inheritance was asked या क्या था? Okay, so here of course desferrioxamine is the answer. We all know that is a chelating agent to chelate iron. Okay, right. The next question, so important topics. Almost every time you get questions on nephritic syndrome, nephrotic syndrome. We've discussed in the main videos also, we've discussed in the marathon also. Again, I'm sure I've got it right. So a 5-year-old child presented with edema, okay, edema for last few months. It started on face, but now it is generalized with pedal edema as well as ascites, okay. He showed good response to steroid. So it is showing good response to steroids. And his RBS, the blood sugar, random blood sugar was 112 milligram per dl. On urine examination, massive proteinuria was there. On CT scan examination, though CT scan was not required, but the finding was unremarkable. And then on electron microscopy of kidney biopsy, effacement of podocytes was seen. Identify the given condition. Yes. So was this the question? So again, no points for guessing this. You all know this is a case of nephrotic syndrome because you're getting generalized edema. Okay, so facial edema and then pedal edema, generalized edema is there. Then massive proteinuria is there. So generalized edema, massive proteinuria. So they go towards the diagnosis of nephrotic syndrome, and it has been there for few months, and it is showing good response to steroid. That means it is probably a minimal change disease, which is most common in children, and it is confirmed by this picture of electron microscopy which is given, which is showing effacement of podocytes. So in minimal change disease, we all know that on light microscopy it will be absolutely normal, but in like electron microscopy you can get minimal change disease. So this is the answer. Yes, and all of you are right. Okay, if it is not FSGS or membranous or PSGN. Trilok, please share the pedigree picture, then we can discuss that if any of you are able to share. Okay, there was protein more than 4.5 milligram per dl in the urine. Okay, so that is massive proteinuria, right? Okay. So Pavan says in pedigree, one parent is affected while other is not. But after that, in every generation, at least one child is affected. So you marked autosomal dominant. Okay. So in autosomal dominant, that makes sense. Either of the parents is affected, then it becomes autosomal dominant. And why autosomal males and females equally affected. And if father to son transmission, you have to see if it is there or not. If father to son transmission is there, it cannot be X-linked. It has to be autosomal. So if a father is affected and son is also affected, it will be autosomal. And if in all the generations at least one of the parents is affected, it is going to be dominant. So it can be easily solved. Okay, so you're telling autosomal dominant pedigree was there, Sadiq. Okay, so autosomal dominant pedigree was there. Okay, and any of you, if you are able to share the picture of pedigree, do share, then we can discuss that also. Okay, so this was there, additional. Fine. So moving to our next question, a 6-year-old child with hematuria. So you have a 6-year-old child with hematuria and presence of RBC casts in urine. What is the diagnosis? So was this the question or any other details were also supplied? Please opine. So what is the answer? Is it A, FSGS or B, PSGN? So A, FSGS is focal segmental glomulosclerosis. B, PSGN means post-streptococcal glomerulonephritis. C is minimal change disease. D is membranous glomerulonephritis. So you can make out that this child is having hematuria and RBC cast. So this is pointing towards the diagnosis of nephritic syndrome. There might be some edema and hypertension in this child also. Okay, some proteinuria can be there. So this is definitely a case of nephritic syndrome. Okay, history of respiratory tract infection was given. Okay, so that again favors the diagnosis. So what is the diagnosis here? The most common cause of nephritic syndrome in children. Yes, what is it? Okay, history of upper respiratory tract infection was there. So more so if it is following upper respiratory tract infection, what is your diagnosis then? Okay, and edema was also there. So edema was also there. So there's no doubt again then for the answer. So very good, Janu, Kiran, your drug of choice. Okay, Praful, Shamshad, Dr. GS, Manoj. Okay. So it is indeed PSGN, post streptococcal glomerulonephritis. So edema is there, hematuria is there, hypertension may or may not be there, RBC cast in urine is there. So it is nephritic syndrome. And a history of upper respiratory tract infection prior to illness is there. And the most common cause of nephritic syndrome as well we know is post streptococcal glomerulonephritis in children. Okay. So good pasture was also an option. Okay, so good pasture syndrome was also an option, but that is not the answer we all know. Okay, thanks for helping. Okay, so the last question I believe which I have from my side, an 8-year-old child presents with high grade fever. So 8-year-old child with high grade fever, restlessness, and is found to have neck rigidity. So restlessness is there, high grade fever is there, and neck rigidity. So it appears to be a case of, so what is it? Is it A, bacterial meningitis, B, tubercular meningitis, C, viral meningitis, D, fungal meningitis? So what was this question? Oh, okay. So you are telling this was a 20-year-old person, is it? Okay. In my recall, I got the question as 8-year-old. So if it was a 20-year-old, so even if it was 8-year-old or 20-year-old, yes, the answer would probably be bacterial meningitis with the given case scenario. But if the history was long standing, say it has been there for more than 2 weeks, 2 to 3 weeks, or even more than that, and the person, the child, or okay, so it was a 20-year-old. Oh, previous question. So this was question 17. You are telling it was a 20-year-old. So which one was 20-year-old? So question 17, was it a child or a adult? Please help with that. And question 18. So you're telling how to differentiate without CSF findings. So clinically also you can get some idea if there is high grade fever and if it is acute illness of say 2-3 days only, and the child is really toxic and restlessness is there, neck rigidity, meningeal signs are there, more chance of acute bacterial meningitis. But yes, viral meningitis or meningoencephalitis still remains a possibility, and in that case more of altered sensorium would be there, and fever might not be so high grade. Fungal meningitis usually we would expect in an immunocompromised individual, okay, or a person who has been ill for quite some time. TB meningitis, you will get the stigmata of TB, like weight loss would be there, low grade fever for quite some time, history of contact can be there can be associated respiratory findings also, so all that can be there. So with this history, short history, you would consider bacterial meningitis. So what exactly was question here? So if you can help by writing in the chat box. Okay, what exactly was question number 18 and what were the options? So, two questions were there like this. Why not see? Okay, so viral meningitis also remains a possibility. So, if some CSF findings or something else would have been there to, further qualified, then it would have been better to say, okay, so hypoglycemia was there. So, was it CSF glucose was low or the blood glucose was low? Whether the value of CSF cells, protein, or glucose was given or not, you can help by writing in the chat box and what exactly were the options, and then we can discuss. Okay, so hypoglycemia was also there. So hypoglycemia was also there. And chest x-ray, you are telling upper low fibrosis. So if chest x-ray fibrosis was there, then of course it is going more towards tuberculosis, and the duration of illness, if it was more than 2 weeks, then that also helps. Okay, and cerebral malaria was also one of the options you're telling. So if you can qualify this question properly, if someone can share the exact question either in your in the Facebook group or in my Telegram group, or you can email the questions to me. So if you feel the questions are any different from what we have discussed, or any other question that we have missed, like the pedigree question or any other question from pediatrics, if you are able to recall, or if there was any change in the structure of the question or in the options, please help me out by emailing to doctor, so dr.minakshi.pediatrician@gmail.com. Okay, there's a E here, not a AE. So if you can email me the exact question and the options and the images, if they were different, any other image based question was there from pediatrics, any questions on immunization, any other questions, I would be happy to help. Okay, so we'll come up again with the rectified, the revised questions, if you feel there are any other changes, any other questions that we have missed, and the refined version of this. Okay, but I'm sure you would have done pediatrics very very well in this exam, and most of you would have done most of the questions correct. So hoping for your best results, and thank you so much for, even after your exam, you are contributing and discussing. That shows your motivation, the level of motivation. Okay, so second paper was difficult, you're telling, right? So Telegram group is Pediatrics by Dr. Minakshi. Okay, the name of my Telegram group is Pediatrics by Dr. Minakshi. So you can post there, or in the Facebook Prep Ladder Premium group also you can post the questions. Okay, so I will be happy to help. Okay, or on the Instagram you can message me, okay, by the name of Dr. Minakshi, pediatrician, right? So there is this elite pack which is coming up, elite pack from Prep Ladder, and you have the updated new video lectures in English, and the next question bank we have the clinical case scenario based, and you can see almost everything has been covered here. So I'm sure you would have heard about it and the discounts and all that you're getting. And now is the time to chill and relax, and think about what went wrong, if it went wrong, and to consolidate your success, and to congratulate yourself, to relax, sit back, give yourself a break, and think what you want to do ahead. Okay, and this is the time that you can give to yourself. Take the time with your family, with your friends, go out, relax, detox, chill, and come back with renewed vigor. So either you will definitely in all probabilities clear it, and then you have to think about your post graduation and all, and start preparing for that. And for very few of you who are not able to make it, I'm sure with the level of motivation that you have, that even on the day after, and just 2 days after the exam, you're still sitting and discussing the questions, that shows it is there in you, and you will definitely be able to make it the next time if you are not able to this time. So all the very best for your results, and I would really love to know your results, and would really wish that all of you make it through, and happy learning. Okay, so all the best, may God bless you. Thank you.